Hello everyone, I am Prateek Kumar Tiwari, working as an assistant professor in IIMT College of Pharmacy, Greater Noida. Today I am going to discuss a topic which is anti-ulcer drugs. Before discussing the drugs, now we have to understand what is peptic ulcer or what is ulcer. Basically, when the injury happens due to intrinsic factors, now we can call it a ulcer. But when the injury happens due to or causes due to the extrinsic factors, then we call it as a wound. So now we have to understand what is peptic ulcer. So peptic ulcer basically a condition in which imbalance of there is an imbalance of aggressive factor and defensive factor. What are that aggressive factor? The aggressive factor are acid, gastric acid, gastrin, pepsin, and alcohol is also there. Spices is there. Smoking we can also add over here because this all causes this all are aggressive factor which trigger the ulcer. And defensive factor are there those which act as a defensive mechanism and protect the wall of the stomach from a ulceration or erosion. So say example are prostaglandin, mucosa, bicarbonate. Age is also we can say defensive factor. Uh, so it is a brief introduction about peptic ulcer. Now we have to, there's a one causative organism, microorganism like H bacter, Helicobacter pylori. It is one of the major etiological factor in peptic ulcer. It causes 95% cases of duodenal ulcer and 75% in gastric ulcer. Drug also induces the peptic ulcer like long-term use of NSAIDs, example paracetamol, diclofenac, aceclofenac, aspirin, etoricoxib. If you use these all drugs for a very long time, it causes the ulcer, peptic ulcer. Okay, so now we have to understand how the acid secretion happens before discussing the anti-ulcer drugs. So there is a different pathway followed for the secretion of gastric acid. So first one is what happens when we take food, it goes into our stomach. In the stomach wall, there is a presence of various receptors such as chemoreceptors. So when we take food, it exerts a pressure on the wall of the stomach, and then that leads to that receptor send a signal to the PNS. Then PNS send a signal to ACH, release ACH, and this ACH molecule bind to the nicotinic and muscarinic receptor which is present on the ganglion cell, and this lead to the release of GRP and ACH. So this GRP, what does? This GRP goes bind to the G cell and release of gastrin molecule takes place, and this HCl goes bind to the muscarinic receptor of histamine, or and this ACH also goes bind to the M3 receptor which is present on the wall, okay, membrane. So what happens when ACH goes bind to M3? It triggers the calcium release, and this calcium molecule goes secretion leads to activation of protein kinase, and activated protein kinase activate the hydrogen potassium base pump, or we can say proton pump, and the exchange of hydrogen and potassium molecule takes place here. And there's a presence of chlorine outside in the lumen, and when the hydrogen molecules go there, it's combined with chlorine and form the HCl, that is acid. So this is the one mechanism. Second mechanism, when ACH bind to muscarinic receptor present in the ECL cell, and gastrin molecule bind to CCK2 receptor present in ECL cell, it's triggered the release of histamine molecule. This histamine bind to H2 receptor, and further it's activated the CMP pathway, and this CMP pathway lead to the secretion of calcium, and this calcium molecule lead to the activation of hydrogen potassium ATPase pump. So again, the formation of acid takes place through this mechanism pathway. Third pathway is when gastrin molecule goes bind to directly to the CCK molecule, which is a receptor which is present on the membrane. It's again trigger the release of calcium, and activation of protein kinase is takes place. This activated protein kinase activate the proton pump, and the formation of acid takes place. So this is the basic mechanism how the acid formation takes place. Now we have to understand the symptoms which is seen in the case of peptic ulcer. So from this chart we can understand there is some common risk factor like stress, H. pylori, alcohol, or smoking, which I already discussed in this video. So what happens? This risk factor causes both duodenal and gastric ulcer. So how we can differentiate the duodenal and gastric ulcer? So what happens in the case of duodenal ulcer? Where we can differentiate on the basis of pain. When we take food, pain is started after 2 to 3 hours. But in case of gastric ulcer, pain is started after taking a meal. So this is a major difference. So we can differentiate in the case of gastric ulcer, eating may increase the pain, but in case of duodenal ulcer, when we eat food, it decreases the pain. So this is the basic difference between gastric ulcer and duodenal ulcer. There is a stress induced ulcer as well, which is occurs due to physiological stress, shock, or curling ulcer, extensive bonds is there. So this is the different type of ulcer which is shown in this chart. And now there's a few symptoms like abdominal pain. There's a severe abdominal pain happens in case of peptic ulcer. There's a loss of appetite. There's a loss of weight. There's a water brush. Nausea and vomiting is there. Now we have to understand the classifications of anti-ulcer drugs. So there is a different approach used for the treatment of ulcer, peptic ulcer. First one is reduction of gastric acid secretion. So in this class we use 4 drugs: proton pump inhibitors. Proton pump inhibitors we can use. We can use anticholinergic drug. We can use prostaglandins analogs, and there's a H2 antihistamine. So first we can discuss there's a proton pump. There's a omeprazole, pantoprazole, lansoprazole. All the prazoles suffix is there, so it is a proton pump inhibitors. In case of anticholinergic, the drug falls in this categories: pyrazapine, propanthyline, and prostaglandin analogs like misoprostol. H2 antihistamines is cimetidine, ranitidine, and roxetidine. So there is neutralization of gastric acid we can do. We can either inhibit the secretion of gastric acid, or either we can second approach we can neutralize the gastric acid over there by using antacids. So antacids are basically falls in 2 categories. One is systematic, and the second one is non-systematic. In systematic, there is a sodium bicarbonate, sodium citrate is there. In case of non-systematic, there is magnesium hydroxide, magnesium trisilicate, aluminum hydroxide jet, and calcium carbonate. In case of ulcer protective drugs, there is a sucralfate, CBS. There is an anti-H. pylori drugs is also there, because we know H. pylori is the one of the major etiological cause of ulcer, different kind of ulcer. So we use amoxicillin, clarithromycin, metronidazole, tetracycline, tinidazole, or in the case of if the ulcer is due to H. pylori. So first we discuss proton pump inhibitors. Proton pump omeprazole basically is a prototype member of benzimidazoles, so which inhibit the gastric acid secretion. It causes the dose-dependent suppression of gastric acid secretion. It means if you increase the dose, the gastric acid secretion inhibition may be increases, and it totally abolishes gastric acid secretion by FSCL, because what happens when we give PPIs, no, it goes bind to the proton pump and deactivate that particular proton pump for 24 hours. So that's why proton pump inhibitors are recommended only once a day. So, and in case of emergency, we always prefer proton pumps, because it directly inhibits the proton pump and give the relief. And the action is it's irreversibly bind to the proton pump and responsible final step and inhibit the final step of gastric acid secretion from the parietal cell. Now, PPIs are relief symptoms more quick in compared to H2 blockers. PPI relief in 2 to 4 weeks, and compared to H2 blockers give relief in 4 to 8 weeks. If we're talking about pharmacokinetics of PPIs, it is bioavailability is 30 to 80%, and bioavailability of PPI is reduced by food. That's why we always recommend, or doctor always prescribe PPI should be taken before half or 1 hour before the meal. So because drug is highly available for the optimal effect. Now, half-life of the PPIs are very short, but its effect perfect or its action persists for 24 or to 48 hours after a single meal. So, and again, what is there? Short life, although is very TF is very less, but the effect or action of that PPI is last for 3 to 4 days. There's a no dose adjustment we can do in the case of renal disease if we give the PPIs. Now we have to we discuss here the adverse effect of PPIs. First one is the headache, diarrhea. It also causes achloroidea, and hypergastrinemia is there. Muscle and joint pain is there. Gastric mucosal hyperplasia is there. If we use PPIs for a very long time, it causes vitamin B12 deficiency. It also causes the risk of fracture of hip. So now we have to understand the therapeutic use of PPIs. It's used in GERD. Second, it used in the case of so PPI is also used in the case of peptic ulcer, bleeding peptic ulcer, and Jollinger deletion syndrome. It used. Now we discuss about the dose which is used for different ulcers. If it is peptic ulcer, we can give omeprazole 20 mg once in a day. In case of bleeding ulcer, we give pantoprazole 40 to 1 mg per day, depending upon the condition. If ulcer is induced due to stress, we prefer to give IV of pantoprazole or rabiprazole. If there's a GERD, then we can give omeprazole or H2 blocker. In the case of Jollinger-Ellison syndrome, we give omeprazole. Okay. Now we have discussed H2 receptor blockers. So there's a drug fall in this category as cimetidine, ranitidine, famotidine, and nizatidine. Mechanism is they have competitively and reversibly block H2 receptor on the parietal cell. The cimetidine and all other H2 blocker antagonists block histamine-induced gastric secretion or cardiac stimulation it causes. So now we have to understand the pharmacological action. H2 blocker reduce the basal and full food stimulated acid secretion. It blocks 90% of nocturnal acid secretion and 60% of total 24-hour acid secretion. Therefore, it's better to be given before night sleep. It's reduce the pepsin activity. It also promote the mucosal healing and decreases the pain actually. And the adverse effect is GIT disturbance is there. CNS effect, in the case of CNS effect, it causes the confusion, hallucination, headache is causes. In the elderly patient, it causes hepatic dysfunction and maybe renal dysfunction. It also maybe causes bradycardia and hypotension if we give rapidly through IV intravenous route. Now, endocrine effect we can see of only cimetidine is there. Although cimetidine is very effective in case of peptic ulcer, but we are not using that due to its side effect. It causes hyperprolactinemia, and second, the major causes we don't use it is anti-androgenic action. It causes gynecomastia. Okay, so. There's a several precautions. Dose reduction of S2 is in severe renal and hepatic failure and in elderly patient. If we now we're talking about muscarinic antagonist. So it blocks the action of ACH by blocking the muscarinic receptors. So when the ACH get blocked, is not going to able to bind to its respective receptor. It doesn't able to produce acid. So there's a reduction in the acid production, and there's a abolishment of gastrointestinal space. Drugs are pyrazapine, telazapine is there, and it also reduces the male stimulated HCl secretion by reversibly blockade of muscarinic receptor. So now we are going to discuss here about prostaglandin analogs, that is misoprostol. Prostaglandin analogs basically decreases the secretion of HCl and increases the protective measures like increases the secretion of mucosa and or bicarbonate and gastric mucosal blood flow. And use of NSAIDs induced peptic ulcer, but H2 blockers or proton pump inhibitors are better. In case in compared to prostaglandin analog, because in case of NSAID-induced peptic ulcer, the severity of the ulceration is very high. So we prefer it is a kind of emergency situation. So for emergency, we always try to give PPIs. So it's directly bind to the proton pump and irreversibly deactivated the proton pump, and we get the patient get the instant relief from the ulceration pain or abdominal pain. Now we second use the antacid because antacids are a very weak basis, so it neutralizes the HCl, and also it's also inhibit the formation of pepsin. Uh, Acid neutralizing capacity so there's a potential of antacid is expressed in the terms of MEQ of one normal HCl that are boiled down to pH 3.5 in 15 minutes by unit dose of a preparation 1 gram. Okay, now we have to discuss the systemic, and there's a two kind of antacid basically, systemic antacid and non-systemic. In systemic there is sodium bicarbonate, which but we all majorly avoid to use this because it's it is very effective, but we avoid it because it causes the rebound secretion. It means it decreases the neutralizes the acid very rapidly, but the withdraw after when we withdraw this bicarbonate solution or sodium bicarbonate therapy, what happens, there's a sudden increase of the acidity. So the terms which is used to define it as a rebound acidity. And then it also the demerits is there, systemic alkalosis, distension, discomfort, and belching is there. And I already told you there's a we avoid using sodium bicarbonate because of rebound acidity, and sodium overloaded causes edema and CHF. So we try to avoid the use of sodium bicarbonate so many times. Now we discuss non-systemic antacids. Basically, it is an insolvent poorly absorbed basic compound. It's react to the stomach to form corresponding chloride salt. And this chloride salt again react with the bicarbonate present in our intestine, and so it's not spread for absorption. So this is all. And there's a magnesium hydroxide, magnesium trisilicate, and aluminum hydroxide. So we always try to give the magnesium hydroxide and magnesium aluminum hydroxide in the combination because magnesium hydroxide causes constipation, aluminum hydroxide causes diarrhea. So for getting prevention from that, we always try to give in combination, so it cross out the its side effect and give the desired effect. Megalrate is also used in combination. Basically it is a hydrated hydroxide magnesium aluminate. It is. No, there's a sucralfate. Sucralfate is an aluminum salt. The mechanism of action basically in acidic environment, it's from the cross linkage molecule to form a sticky viscous gel, and then it adheres to the ulcer crater. More on duodenal ulcer, it's have a astringent action and act as a physical barrier because it's from the layer. So in case if it is formed the layer over the ulcer, so it is acid is not going in the direct, causes the erosion and all the things. So it's provided the act as a barrier in the case of peptic ulcer, and dietary proteins also give the get deposited on that layer and give forming another coat and increase the protection over there in from the acid to the ulcer, and ulcer get started healing. Uses it is used in the bile reflux gastritis, prophylaxis of stress ulcer. Ideas are constipation, hypophosphatemia. Is there drug absorbs many drugs and interferes their absorption. So second is we are going to discuss a colloidal bismuth substrate. The mechanism of action is CBS, mucosal form glycoprotein bismuth complex which coats ulcer crater and increases the secretion of mucus and bicarbonate through, because as we know the mucus and bicarbonate is act as a defensive factor. Increase of mucus and bicarbonate secretion, it's started the help in the treatment of our in the case of peptic ulcer. It also helps in the detachment of H. pylori from the surface and directly kill them. So now we have to understand about little bit about H. pylori before discussing the anti-H. pylori drug. So first is there the it is a spiral shaped bacteria. pH sensitivity is basically it is a gram-negative bacteria. It attaches to the surface of epithelium because the acidic pH there's no bacteria survive, but somehow H. pylori is able to survive because there is a coat on the bacteria of urease, which is and the bacteria is inside that membrane of urease. So acid don't able to kill it, and that's how there's a adenosine as well. So adenosine help in the sticking of H. pylori on the wall of stomach, and when once it get attached to the wall of stomach, it causes the injury. We use several antimicrobials in case of anti-H. pylori induced peptic ulcer like amoxicillin, tetracycline, and metronidazole. So now we used two different drug regimen therapy. First one is triple drug therapy, and fourth one is quadruple drug regimen therapy. In triple therapy, the we use the omeprazole means PPIs plus clarithromycin, and either we use metronidazole or amoxicillin. This for 2 weeks. Basically, this is the best among all the triple regimen drug therapy present over there. Now fourth one we can use is for other drug is a triple drug therapy are amoxicillin plus omeprazole plus tinidazole. But best one I already told. Now thanks for this. This is the all about anti-ulcer drugs.